going to go into our next lecture, fluoroscopy, radiation safety, and needle placement. I want to thank David Schultz for providing these slides for today's lecture. And actually, all of my lectures today were provided by previous speakers following that format that Lax talked about, so that the lectures that are given consistently and in the same manner, regardless of who the speaker is. Okay, let's see here, it's the pointer, and okay, there we go. Disclaimer, I'm the president-elect for the American Society of Interventional Pain Physicians. I'm in the practice with Mid-Atlantic Spine and Pain Physicians in Newark, Delaware. I have no conflicts regarding this lecture. I am a consultant for St. Jude's Medical, which involves educational aspects. St. Jude's Medical pays Temple University Hospital, where I'm the director of the Pain Medicine Fellowship Program. They pay them about $30 to put on a symposium once a year for all the residents in the area, in the Delaware Valley area. I'm located in Delaware. So the Philadelphia, we draw from New York, we draw from New Jersey, Maryland, where we get residents come in for a full day symposium about interventional pain management. I also perform physician-to-physician educational sessions when they come to the office, and I do get a fee for that. And that's the extent of that. With JoyMax, I'm a consultant for them, also educationally based. I have physicians that come to the office and do a one-on-one with them. Sometimes I get paid, sometimes I don't. but I enjoy doing those things. Overview, we're going to talk about historical perspective of radiation safety, the fluoroscope and its individual components, fluoroscopy in the modern pain clinic, needle placement for some of the procedures. It won't be exhaustive. Some of the other lectures will be covering that. And here is a slide looking at the evolution of imaging. So let's talk about the imaging modalities. You basically have X-ray, CT, and MRI. We have nuclear medicine thrown in here too. X-ray, inexpensive, great for bone, poor for soft tissue, although how many times have you recognized doing these procedures in your office that with fluoroscopy you can see the shadows of the disc, okay? See the shadows of the nerve root. When you have a foraminal view of the lumbar spine or the cervical spine, particularly the cervical spine, how many people see the exiting nerve root? I see those shadows, okay. CT, much better for bone. You do get some soft tissue attenuation, which is certainly much better than X-ray, although MRI certainly is the best in terms of soft tissue, musculoskeletal imaging. Bone, it's okay, although CT certainly is better in terms of looking for degrees of stenosis or bony changes. CT myelography still considered the golden standard for evaluation of the cervical spine for central canal pathology, disc pathology. It's not unusual that MRI, being a computer-generated image, can subtract out a disc protrusion, and it does happen occasionally, not often, and you'll pick it up on a CT myelogram. MRI, of course, in terms of physics, not only involves radio frequency waves, but also the magnetic resonance in terms of exciting electrons to go to different levels, or aligning electrons in a certain plane. It's the RF that brings them up to different electron valence levels. And when the RF is turned off, they drop, giving off kinetic energy. Okay, a little bit about the history. Going back to 1985 with Röntgen, who discovered X-rays. Madame Curie discovered radium. Radiation injuries can become increasingly common, and we'll see some studies here showing average times for imaging different procedures. Can you believe this? The first malpractice for X-ray injury back in 1905. Huh, that's something. 1929, National Council on Radiation Protection and Measurement put out some guidelines, and the FDA came out with warnings regarding the use of fluoroscopy in 1994. Now, we're not the only ones who use fluoroscopy to a significant degree. Cardiologists use it a significant amount. You'll see gastroenterologists using it as well for interventional procedures, cardiac catheterizations, and stent placements, and even now, percutaneous aortic valve replacement. So fluoroscopy has become a very important tool in healthcare. There's Röntgen looking pretty sharp there with that beard. What do you think, huh? Looks pretty good. Rankin's experiment looked at a cathode ray tube enclosed in a box. He applied a current from the cathode to the anode. The anode hit a metal, tungsten, which gave off that irradiation by creating irradiation energy. And the rays that were produced were called X-rays. Evacuated glass tube in which a stream of charged particles creating the cathode flow towards the anode. And we'll see a picture of that right here. And as it hits the target, here's our electron source. There's a metal target, electron beam, and then that releases the X-ray energy. There's a lab. There we go. Okay, Rankin's big idea, to use this irradiation to see if we can image human tissue between the X-ray beam and then creating a viewing medium. So here he looked through a viewing device here. We have the irradiation that's passing through the hand and then hits an X-ray plate, creating an image of the hand. Interaction with matter. Matter is, X-rays are absorbed by matter, absorbed by the denser materials. They pass through those that are less dense. There is some deflection and scatter by matter. The absorption or scatter of X-rays is proportionate to the matter density. So if we look at radiological densities, we're talking about air, fat, water, and bone, where the X-rays pass through air very easily, and bone not the case, where we are able to visualize bone using X-ray energy as well as metal. So X-rays are ionizing radiation. The imager, the image intensifier, is coated with phosphor, which emits light, which is then turned into electrical impulse and then is then created into an image. With X-ray, the ionizing radiation hits the photographic plate, and that creates an image as well. X-ray tissue penetration, again, low density, pass through, example, air in lungs and the bowel. You can still see outlines of bowel, the shadows of a bowel. High density, where there's absorption or scatter, is going to be calcium, bone, contrast, and metal. Tissues do cast shadows, as we talked about earlier, and if you look hard enough, you can see that when performing your procedures. Fluoroscopic X-rays, the physics, dose reduction, and anatomy. So there's a conversion of electron kinetic energy to electromagnetic rays or resonance. The electrons are boiled off an X-ray tube that is coated with tungsten, the anode, and X-rays are generated by two processes, either via general radiation that is emitted or characteristic radiation. The fluoroscope equipment design is that at the bottom here, we have our X-ray tube. The cathode and anode is here. It creates the electrical energy. It hits the image intensifier that is coated with phosphorus, and from that, light is emitted, and that light then is transferred to an electrical signal that goes to the processor, and we create an image. We will be talking about beam attenuators, which can focus the beam, reduce scatter, reduce and get a sharper image on the fluoroscope. The tabletop also helps to absorb some of the radiation, so reduces the radiation to the physician, whether standing on one side or the other. And of course, the person's body also absorbs radiation, so there's less radiation transferred to the physician or surrounding ancillary personnel. So, advantages and disadvantages. Well, cost. Yeah, I mean, if you buy a brand new fluoroscope these days is about $120,000. Maybe you get a discount for $110,000. So I'm not sure it's that cheap. Ultrasound certainly a lot cheaper. A lot of other equipment a lot cheaper. Although on the refurbished market you can get a C-arm, a decent C-arm, for much less, $20,000, $30,000, $40,000. You can get an OEC 9600, and you can still find some supersede 9600 OACs for about $60,000. So you can get it for half of buying a brand new fluoroscope. Certainly available. There's a ton of fluoroscopes out there, particularly on the refurbished market. There's portability with the C-arm, screening. Disadvantages: a two-dimensional image, ionizing radiation. We talked about that. But fluoroscopy, more than any other tool in interventional pain management, has done more to revolutionize what we do today. And think about spinal cord stimulation. Think about vertebroplasty, kyphoplasty. Those procedures we are able to do today because of fluoroscopy. Then you think about all of the safety issues with all the different injections we do, with precision placement of needles, the ability to image contrast-enhanced needle placement in terms of ease of procedure, comfort, and safety. It really has, in my time, has been the most important aspect of transforming to where pain management was before to what it is today, for sure, to ensure that you're not in the wrong place, you're not intravascular, not intrathecal, but you're where you should be. So if the fluoroscopic components, you have a source for creating electrons and creating irradiation. This results in X-rays. You capture those X-rays after leaving the target on the image intensifier, and then an image is processed and produced on the fluoroscope video screen. This is the generator. This is where you're generating energy that's plugged into a outlet, and this is where you get your direct current. That direct current can be adjusted in terms of current and voltage, either automatically or manually. You can make those changes, which is very helpful, particularly if you have someone who's very thick or very heavy. You have your X-ray tube. This is where your anode and cathode are at. The DC flow allows for the charge for the electrons to flow and hit the anode, and X-rays are given off as those electrons interact with the metal, typically that is tungsten. It's a very inefficient process, and as you know, working with fluoroscopy, you can feel the heat coming off of the fluoroscope. So you got 90% heat and 1% X-ray. You can use your collimators to help to focus the beam. You can rotate the C-arm to also change your beam orientation. You can modify the size, the shape of the X-ray to conform to the field of view. So if you're looking just for a foraminal area, you don't have to see the entire cervical lumbar spine. You can collimate in just on that one segment, whether it be discogram, a particular level where you're performing an interlaminar epidural. You can focus that down. This helps to reduce scatter by reducing the volume of tissue that's exposed from the X-rays, and reduces that irradiation that can be scattered to the physician and surrounding ancillary personnel. Improves image quality by reducing image degradation as well. So there's our II, the image intensifier. Native fluoroscopy images are dim. The image is intensified. Image intensifier intensifies the image. It converts X-rays into light, hitting the phosphorus, and those photons that are converted into an electrical signal. And the image intensifier is able to amplify the brightness of the image 5 to 20,000 fold. So here's, this looks like an OEC 9800. So you're plugged in here. Here's the X-ray source. This is in white, and I changed it last night into black, but you're not going to be able to see that, unfortunately. But there's that. Here we have our anode and our cathode. This is where we're creating our X-ray beam. So AC current comes in, it comes here. We create the X-ray. Phosphorus is created, and the OEC, or the image intensifier, creates a bigger signal. That gets sent over to the fluoroscope there on the left side. These aren't my specific slides per se. Some of these are funny, some of them are concerning, some of them are sad, but we'll move on without comment. Okay, X-ray physics parameters. We're looking at the beam energy, the KVP, the tube current, milliamps, collimation, tube to patient distance, the II distance, magnification, patient size, and beam on time. Fluoroscopic radiation exposure, patient, operator assistance, and tube leak. So here we're looking again at our 9800 here. Beam comes through, scatters, okay, when it hits the table, but some of that is absorbed by the patient and some of that is absorbed by the table itself. And so now here with collimation, we have a shorter beam, a more focused beam, and by using collimation now we have less scatter. So this is a diagram example or diagram showing you that with collimation you can get less scatter as opposed to without collimation, okay? With collimation, without collimation. With collimation, without collimation, okay. And then we get our image picture here. Now, also how the C-arm is oriented to the patient. So if you have your II on top, you have your X-ray source below the patient. The amber color here is showing you where the scatter is going. So the scatter is greatest here, okay, away from the face, away from the feet, but here's where most of the scatter is. So having your thyroid shield, your lead shield is really important here. We're going to see a couple more of those images showing the difference in C-arm positioning. Fluoroscopic dose reduction, really important. These are the 5 things. So if there's one thing you take away from the lecture, it's this slide. You can throw everything out, save this slide, time, distance, collimation, technique, and shielding, right? So the more time that you have the C-arm on, is there more radiation exposure or less? More, okay? If you stand further away from the C-arm, I'm over here, am I exposed to more radiation or less? Less, okay. Collimation, and you saw that diagram, we went back and forth. If I make the beam concentrated, so now it's not as broad or wide, is the scatter less or more? Less. Technique, so if I use continuous fluoro versus intermittent fluoro, am I getting more radiation with continuous or less radiation? More, right. If we use pulsed imaging fluoroscopies, that give you more or less? Less. Great. And shielding, okay? Thyroid shields, lead shields, and we'll show some studies that show that the amount of exposure to your body by having the shields on is significantly less. So does shielding protect you from radiation? Does it reduce your exposure to radiation, or does it lead to more exposure? Less. So those are the 5 things that you can do to limit your exposure to irradiation. I think it's very simple, very easy. Time, distance, collimation, technique, and shielding. Continuous versus intermittent. Okay, we talked about that. Beam on time, reducing that. Who controls the pedal? Okay, well, a lot of times the physician controls the pedal, so you got to be wary about that. If you have someone else controlling the pedal, and this happens all the time. How many times does this happen that you're doing a procedure, someone else, you're in the hospital, and because you're not an X-ray tech, you can't have the pedal, right? So someone went to school for 2 or 3 years so that this finger can now turn the C-arm on and off, and you can't do it. So what happens is you say on, off, or I don't know, what other acronyms do people use? I say on, off. What do other people say? What's that? Fluoro or shot or this or that. So what happens? Okay, you say fluoro, they turn on the fluoro, okay, say off, it's still on, your hands get into the field and they're x-raying your hands. So your hands get x-rayed about 15, 20 times during a procedure because they're not paying attention, they're on the phone, you know, they're looking at their iPad, whatever the case may be, and so you get a lot of exposure. So if the doc has control of the pedal, I would dare say that the exposure would be less, okay. If you have last image hold, another great idea. If you can hold the image, that's great. And this also reduces exposure. Do you really need to keep it on all the time? No. Okay, adjust the image, all right. So if we look at the mean fluoro time for common pain procedures, and this was published by Zhao et al. In Pain Physician, the average time for ESI was just above 40 seconds. For discography, 160 seconds, so a little over 2 minutes. Well, not quite, less than that, about 120 some, 130. If you look at the fluoroscopic time by physician in that study, You can see there's a variation of time. Okay, so time is not only dependent upon the procedure, it's also dependent upon the user. Okay. This is a study published by Dr. Manchacanti showing that colopidurals, an average time of 3.75 seconds, plus or minus 0.13, with a range of 1 to 27. But you can see different procedures, oh, that didn't come in. Okay, different procedures take up more time. So for example, if you're looking at spinal endoscopy, closer to 40 seconds with a maximum of 46 seconds. So this is showing how different injection procedures require more time than others. And also, what this doesn't show, but which is also inherent in using fluoroscopy, is the user. How fast is the user in performing the procedure? Okay, here we're talking about distance, okay? If you take 2 steps back, you have a 4th reduction in your exposure to the irradiation, okay? So it's not a linear relationship, it's a squared relationship. So if you're 3 feet away, it's 9 times further away from the fluoroscope. And this diagram will show you how it's not a linear relationship, that the further you step back, as the significance of the reduction of the X-ray exposure is seen, okay? Limit the field of view to areas of interest, collimation, reduce the dose exposure to the patient, to the operator, assistants, scatter, and improve the quality of image. And we have a couple pictures here. These were provided by Arthur Watanabe, a neuroradiologist, and I don't know if he's in California. Is Dr. Watanabe in California? I'm not sure where he's at, quite honestly. But you can see here a wide open field of view. Here is a collimated field of view, and you can see the structures of the lumbar spine here much clearer, and of course less exposure, all those good things. Fluoroscopic dose reduction, okay, technique. So we talked about this, continuous versus pulsed, half the dose. C-arm positioning, cross-table lateral, bad, particularly if the anode and cathode are on your side. So if you swing the C-arm around, so the II is on one side, and then you have the anode cathode, the generation of the X-rays on the other side, and you're right there, you're getting direct exposure. And not only that, even if you're on the other side, you're not getting the advantage of the absorption of the X-rays in the table, and it's just going across to the patient. So you want to stand back. That's where you really want to stand back and take your image. Obliquity, depending upon the size of the patient, that can block some of the X-rays, because if you have a nice round person, you're going to get some better absorption because when they're lying on their stomach, sort of spread things out. But that's going to alter the scatter. We'll see 2 images that will show the alteration of that scatter. Okay, image intensifier position here. Fluoroscopic dose reduction. We talked about this pulse versus continuous digital technique and digital subtraction angiography, which all affect the signal to noise ratio, not signal to noise ratio. Okay, here we see some collimation, again trying to target our area so we get less exposure, better clarity of our image. Normal versus high dose fluoro. High dose fluoro, you're going to get more exposure, but it can help to reduce your signal to noise to get a better picture, particularly with large people. Pulse fluoroscopy reduces. Now, here we're talking with the oblique. So here in the oblique, with here we go. With the X-ray generator here, okay, generating X-ray here, here's the II, image intensifier. Okay, so what happens here is that this is closer to the physician, and we're going to get scatter in this direction, so you get higher exposure to the eye. So that's why it's important, in addition to your thyroid shield, in addition to your apron, that you're also wearing your glasses to prevent exposure to the eyes. Now, the opposite is true. If we turn it this way, so now the X-ray tube is away from the physician, the scatter's in this direction, so more of it is going towards the feet, and you're getting lower eye exposure. So the positioning of the C-arm certainly impacts not only on the characteristic of the scatter, but what areas are going to be affected by that scatter because of that change in orientation. Some physics parameters regarding KVP and current, your milliamps. And you can see here that if you increase KVP, decrease MA, it increases patient exposure and decreases your contrast of what you're imaging. Doing the opposite, decreasing voltage, increasing current, you get an increase in both. You get better contrast, but increased patient dosage. Tight collimation, great. Decreased patient exposure, increased contrast, right? You get the best of both worlds right here with collimation. So collimation is really important. If you increase the tube patient distance, you're going to get decreased patient exposure, but decreased contrast. And if you decrease the patient eye distance, you're going to get decreased the image intensifier. You're going to get decreased patient exposure and increased contrast. So these two, tight collimation and decreasing the patient to the eye distance, provide you what you really want to get is reducing the exposure to the patient and surrounding ancillary individuals and physicians, and you get an increase in your contrast delineation. Again, protection, 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 shielding, 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 aprons, glasses, gloves, freestanding table aprons. This is kind of somewhat controversial. But certainly you can have those freestanding shields, or some people have those shields coming down from the ceiling to protect them in doing procedures. I'm sure you've seen that as well. Here are protected devices, dosimeters. So here's a study published by Dr. Mangiaconti looking at placement of the dosimeter, and with wearing your proper attire, you can see that when you're inside, with your thyroid shield, you're getting zero exposure. When you're inside the chest with your apron on, you're getting zero exposure. And when you place in the groin area, if you place underneath the apron that's covering the groin area, you're getting significantly reduced exposure compared to what the exposure is outside of your shielding. And that's highlighting those three right there. Okay. There's no good reason or technique for your hands to be in the beam ever. And again, even wearing protective X-ray gloves, if anything, if it's on an automatic, it's going to increase the current or the voltage to penetrate through your hands. I'm sure some of you, if you're having trouble with an automatic C-arm and you're not getting the contrast or the degree of penetration that you want to get to see your structures, one of the simple things to do is you put a Kelly clamp in there or an Army Navy or something. Okay, so it increases you're without turning on a switch, you're increasing your KVP to penetrate through the metallic instrument, so you get a better clear view. Same thing here. You're putting your hands in there, and the image intensifier automatically increases so that it can penetrate and get a better picture. So you're actually getting more exposure, not just to your hands, but to your body and everything else. So that's the controversy about using radiopaque gloves. These are the freestanding shields here, right over here, and things that can be attached to the table side. Potential hazards, the FDA, again, talking about this warning in 1994. Angioplasty, cardiac catheterizations, stents, a lot of cardiac stuff. Here's some GI stuff, percutaneous, transhepatic cholangiography, transhepatic, percutaneous nephrostomy. So here's some renal stuff, biliary, GI, urinary biliary stone, uro. So procedures typically involving extended fluoroscopic time. This induces skin injuries to patients. We're going to see some ugly pictures here of irradiation to the skin. Actually goes beyond the skin down to the muscle here. Contrast allergies. So if you're using a contrast medium, make sure that you ask your patients about history. Do they have a history of an allergy? And then consider not premeditation, but premedication. But you could also do premeditation too. So actually, probably should sit with the patient, sit down in a Indian type seated position, hands up, and have your mantra and help everyone to relax and let the stress leave the room. But you certainly want to try to avoid iodine contrast. You can consider, a procedure without contrast, depending upon the procedure. And alternative contrast, gadolinium, certainly is a viable option. So how do you manage the contrast allergy? Well, things that you can see with the contrast allergy are complaints of nausea, vomiting, heat sensation, pruritus. You can certainly get urticaria. In terms of the progression of the allergy, which gets hairy, is that you can get laryngospasm, bronchospasm, and an arrest. The incidence of a contrast allergy, certainly a lot less with non-iodine-based contrast. A mild reaction to the contrast, about 2.5%, moderate 1.2%, and severe, pretty rare, 0.4%. Although with the numbers of procedures being done throughout the country, you can see that it certainly is happening. Pre-medication for contrast allergies, you can use methylprednisolone or prednisone. You can use histamine antagonists. That's typically what we do, or the use of gadolinium in these patients. Depending upon what their past history has been. Of course, the past history may not predict. They may have had some mild responses or side effects from the contrast. Doesn't mean they couldn't have a more serious one with the next procedure. Here's your alternative. This is a contrast medium, non-iodine contrast medium. This is GAD. So you get pretty good contrast enhancement there with the GAD under X-ray. Use of GAD. Here we have use of GAD. Looks like this is an intraarticular facet joint injection. You can see some contrast GAD here in the inferior recess, just a tiny bit here in the superior recess. Here we see hip injection. You see some GAD here. Here we are in epidural. You can see some GAD there. Spine fluoroscopy diagnostic and therapeutic injections. Okay, there's some more political fodder. Interventional pain. We're going to go some cervical radiology anatomy. And looking at the pre-vertebral soft tissue areas, imaging C1 to C7, looking at your sagittal alignment, lordosis, disc heights and facet joints. Here are your spinous processes in the middle, uncinate processes. Laterally here, you have your lateral masses here with some of the facet joints, disc base, and lung apices. Here's an oblique view. You can see your foramen very, very clearly. You can see your ipsilateral, contralateral pedicles, vertebral body. The lamina is here, facet joints in between. Here's a close-up of the CO, C1, and C2 joints. View of the MRI prior to an epidural. Here you can see where your epidural space is here at C7, T1. And this is a T1 sagittal view looking at epidural fat. Cervical interlaminar epidurals, patient is prone, head, neck flexed. Depending on what you want to use in terms of a needle, contrast, loss resistance technique. Here are some views again supplied to us by Dr. Watanabe. And here he's using an oblique approach to get to the interlaminar space, showing contrast medium spread here. This is typically very helpful if you have a person where you're going at C7, T1, they're very large, you can get the shoulders out of the way, and this gives you at least the ability to get a look at your contrast flow in the posterior epidural space here. Many interventionists avoid this procedure like the plague, like Dr. Mangiaconti was talking about, because of the unfortunate consequences of transforaminal injections in the cervical or lumbar spine for that matter. And the mechanism, although felt to be due to particulate steroid, I know I've reviewed several cases, and there's at least 2 cases in the literature where there may be 2 mechanisms. Maybe there is vessel spasm. Maybe there is an intimal flap from the radicular artery. I'm reviewing a case right now, cervical, transforaminal, 3 levels. Typically, when you see a complication from transforaminal injection, it's immediate. It's within 30 seconds to a minute. They can't transfer off the table. And there are at least 2 studies in the literature, and one that I'm reviewing right now, 1 lumbar, 1 cervical. The one I'm looking at is cervical, where the patient after the transforaminal was able to get off the table. 25 minutes later, started to have the slow progression of neurological deficits, motor and sensory. And in all three cases, near complete resolution 12 to 18 months later. So they went from being significantly paralyzed to the ability where in the cervicals typically have a Brown-Séquard type presentation, so both sides are affected. The weakness is dominant on the injection side, less so on the other. The sensory changes also tend to be greater on the injected side. But then you look at 12 months, 18 months later, it's almost like a rind, you know? So particular story may not be the only mechanism. So interesting stuff. But nevertheless, I think doing everything right in terms of using a non-particulate steroid, in terms of using tubing, in terms of using continuous fluoroscopy, using digital subtraction, using your lidocaine test dose before injecting, all those things I think are very important. There was an article published in JBJS where they took pigs, they took, I think they didn't use depomedrol, I think they used triamcinolone, maybe depomedrol, triamcinolone or depomedrol versus depomedrol, and they found that, not depomedrol, not betamethasone, what's that? I'm having a Perry moment here. What was that again? Yeah, dexamethasone. Thank you very much. So dexamethasone, all the pigs that got the particular steroid stroked and died, and they injected in the carotid arteries, all who got the dexamethasone survived. So it certainly leads to the credence, or leads to the likelihood that particular steroids is probably one mechanism for sure, but it may not be the only mechanism. Okay, now I think I'm going to go on the David Letterman show tomorrow night. Okay, so you might see me tomorrow night after that mental lock there. Okay, cervical transforaminal epidurals, and this is an oblique view off the supraarticular process. Again, provided by Dr. Watanabe here, and showing contrast flow. Here's PSA, or DSA, excuse me. Digital subtraction angiography. Cervical facet blocks, posterior approach, lateral approach, supine oblique approach. Here is a lateral approach, and you can see the contrast filling the superior and inferior recesses, as well as the joint space. Medial branch block. Here's radiofrequency probes placement for rhizotomy. Here we're looking at the stellate Ganglion block. I really call this a cervical sympathetic block because the needle is placed anterolateral on the vertebral body. And of course, where you place the needle depends upon what you're trying to accomplish. If you're trying to accomplish relief of neuropathic pain from trigeminal neuralgia, you want your needle placed a little bit higher, obviously. If you're trying to get the arm, then you want to make sure that you get the thoracic sympathetic, so you want your needle to place lower on the cervical spine, C7, as in this example. Thoracic fluoroscopy, diagnostic and therapeutic injections. Looking at the anatomy here, the paravertebral anatomy, we have lungs over here. We have a cardiac silhouette. We have pedicles, spinous processes. You're all familiar with this. Paravertebral soft tissues, sagittal alignment. And of course, the thoracic spine has a notable kyphosis, disc height technique. Rib, transverse process, very important for performing your medial branch blocks. There's rib. Here's an oblique view looking at how to get into the inner space here, whether you're doing a discogram or even if you're doing a selective nerve root block. The rib head provides the posterolateral border, the SAP, the anterolateral border, and the end plates above and below. Okay. This is just for pre-injection planning. And again, here we have oblique, and we have our pedicle, we have our rib, we have our supraarticular process, lamina there. Once the needle has reached the inferior margin of the joint, further insertion should be performed in the contralateral view to see where you're at in terms of an interlaminar injection. Needle should be inserted until it reaches or just passes the inferior margin of the joint. I think he's talking about, this is a facet injection, I take that back. This is an injection into the thoracic facet joint, okay? So you start in AP, 1 or 2 segments below, depending upon how large the patient is. And then once you get close to the facet joint, you get a contralateral oblique to advance the needle tip into the posterior inferior aspect of the facet. So patient prone, thoracic spine, flex, interlaminar space. We're talking about thoracic interlaminar epidural injections. Interlaminar space, different, high, low, or medium. So at the lower part of the thoracic spine, you're going to have caudate tilt. At the middle portion of thoracic spine, you're going to have an AP view of the C-arm, head here, feet here, head here, feet here, thoracic spine. So lower thoracic spine, caudal tilt, middle, straight up and down PA, and then a rostral tilt for the upper part of the thoracic spine. Okay? Needles, contrast, your preference, and loss resistance technique. Okay, so let's move on to the next slide here. Here's just a picture, looks like from Gray's Anatomy, showing what the bony landmarks are here and the ligaments of the thoracic vertebral area. Here's T3, T4, so you're going to have a more rostral tilt to square off the end plates. Then you can do a contralateral oblique to see where your position is in terms of the lamina. These pictures provided by Arthur Watanabe. I would suggest that the injection contrast here probably is not in the epidural space. Would anybody disagree with that or agree with me? Looks more like it's a fascial injection there. This looks more like an epidural contrast right here, and that certainly is epidural. Okay, medial branch blocks. Actually, we're doing transforaminal injections, and again, we can use this oblique view, identifying the space between the end plates and the rib and the supraarticular process. Here are the pedicles, and you can pass your needle tip right through there, looking your AP and your lateral to make sure, on your AP, that you're not beyond the medial particular line, and on lateral, that a needle tip is inferior posterior as much as possible to avoid the radicular artery. And these are medial branch blocks, and in medial branch blocks, the positioning is in relationship to the transverse process, not to the supraarticular process. You got to keep that in mind. And here's a thoracic splanchnic block. Again, you can use that oblique approach to get to your position, and then you can advance your needle on AP and lateral to get to your final resting place. Lumbar injections, this cadaver specimen showing the relationships of the pedicles to the nerve roots as they're exiting the dorsal root ganglion in the intervertebral foramen and the thecal sac. This is outlining the safe triangle technique, which is the unsafe triangle technique. Again, placing the needle tip anterior and superior is not a good place to put it. If anything, you want to put it as inferior as you can and as posterior as you can to stay as far away from this exiting nerve root. So placing the needle tip over this exiting nerve root to the safe triangle between the pedicle against the vertebral body, and then you have your exiting nerve root forming that safe triangle. That safe triangle is not safe because this is where your radicular artery is. So posterior, inferior is the way to do that. And I'm almost finished. This is 124 slides or whatever it is in whatever time we have here. So that is not the safe place. X that out. Pretend I didn't show that to you. This whole approach is just not the way to do it. There is no safe triangle. And that should be talked about, just demonstrated and gone over in the cadaver lab. Okay, that's where you're really placing the patient at risk here. Okay, S1 foramen, S1 transforaminal injections. It's just a matter of two things. You can, because the S1 foramen, we're almost at the end, folks. If the patient's head is here and the feet are here, the foramen, so patients this way, head here, feet here, the foramen are somewhat rostrally located and laterally tilted. So if you have trouble seeing it, one thing you can do is you can tilt the C-arm, and then you oblique to the ipsilateral side of the injection. and that way you can see it very clearly. Remember, the dorsal foramen is a lot smaller than the ventral foramen. So sometimes you see this big foramen, well, that's the ventral side. So you aim for that and you're going to hit bone. But in order to see the foramen, if you're having trouble seeing it, just tilt the C-arm rostrally or laterally or both. Typically, one of those adjustments typically works fine. You don't really have to combine both in performing this procedure. Lumbar facet injections. Basically, you're lining up the facet joint line and placing a needle into the joint. Bevel mechanics, I think this is pretty cool. I think, you know, the needle goes opposite of the bevel orientation. I know you know that, but just to reiterate that. Putting a bend away from the bevel makes the original bevel in the straight a larger bevel, so you get much greater the ability for the needle to deviate to a greater degree away from the bevel. And you can trail your needle so that it goes straight down as you're advancing it to your target zone. This is really good stuff too, because, you know, pushing the needle sideways when you're superficial, you can direct it. Of course, the larger the diameter, the easier it is. When it's in deep tissue, you do this, all you do is bend the needle. And I know when I talk to the fellows, I'm using the arc technique, if you will, by creating a bend to give you a curvilinear shape of the needle will allow the needle to go, but you have to put the curve opposite of the direction in which you're going. And that should be it. So I want to thank everybody. I appreciate your attention, and I appreciate your focus during a very rapid-fire lecture. I think we went over a lot of important issues. And just remember, time, dose, distance, shielding, collimation. Okay? Thank you very much.